Is we're going to have four different cases, and the idea is that we're just going to talk about it and kind of work through it. And I think we could honestly, I don't think we need to break everyone into breakout rooms. I think we could just kind of just go for it from here. So again, if you guys are comfortable, like please turn on your cameras. If not, like if you could just turn on your audios just to help make this more interactive, or you could put anything in the chat, that's fine too. So let me just share my screen. Oh, and also, Mahita, if you could introduce yourself.
Sure. Hi, everyone. My name is Mahita, third year medical student at ATSU Soma. I'm also part of the JEDI Committee, and great to have you, Dr. Bauer, here today. So, yeah.
Okay, so we're going to go over the first case study. So we have Raul, a 60-year-old Hispanic man who is recovering from a knee replacement surgery. He's been seeing a curandero, which is a traditional healer for pain management in addition to his prescribed physical therapy and pain medications. His family believes strongly in the curandero's methods and they encourage Raul to rely more on these treatments. Feels torn between his cultural beliefs and the need to follow his doctor's advice. Okay, so the next slide. So now we're going to talk about, okay, so how would you approach the situation with respect to both Raul's cultural values and the importance of conventional medical treatments? How can you foster a partnership with Raul and his family that incorporates both traditional healing practices and conventional medicine? What strategies would you use to ensure Raul feels heard and respected while still ensuring he receives optimal care for his recovery? So, before we get started with this, I did want to kind of go over briefly the curandero. So I know we mentioned it, but does anyone feel comfortable like sharing like what their idea of like a curandero is, or if anyone knows? I also have a slide on it, so we can also like briefly talk about it. But I think this is important to mention because, you might encounter a patient that has these beliefs. So I think it's good for us to just kind of be aware of what that entails. So I guess we could go on to the next slide and then we can talk about it. Um, I think, yeah. hmm Okay, so curanderismo is something that a lot of people in Latin America communities use in the U.S. So they address physical, mental, and spiritual ailments using a blend of indigenous Spanish and sometimes Catholic influences, using like herbal remedies, prayers, ritual, massages, and spiritual guidance. So there is a lot that goes into this. So that's why I do always think it's important to again like being aware of this and sort of um, keeping that in the back of your mind if you have like a patient that brings this up to you. Okay, so I guess we could go back. Okay, so do we have any volunteers that would like to share like how they would approach the situation? I guess you could go back so they could look at the case report again. So how would you approach Raul? You know, he's having these issues, but his family's pushing him more towards curanderismo. He feels conflicted. What are some things that you would want to address with Raul?
Okay, cool. If not, I'll take the word, guys. So I will talk from my personal experience, but first I would like to note something. Like in PM&R, we often work with patients during vulnerable moments, so we need to understand that. So like recovery from injury, patients in chronic pain or disability. So these moments are not only shaped by the medicine, the usual medicine that we use, they are shaped by the culture of them. So in these studies, this is the purpose of this, like how we should approach it with cultural humility and empathy for this type of patient. So I will put my first thought here. So first, I will go to ask to Raul. Okay, Raul. So what do you think we were doing? First, to understand what is his point of view, and also I would like to ask Raul, what is your curandero going to do with you? Second, and then when we will have that understanding of those scenarios, we can tailor the approach, the specific approach with Raul. Also, for you guys, like as a recommendation, like the approach should be non-judgmental. Always show like curiosity. This is something that I always use, like when I practice in Ecuador, like when I had people from other regions of my country, and are using that now when I encounter patients from other countries of Latin America. I ask with curiosity because I'm curious too. So I would like to understand what are their beliefs. So, hey, but what they do this and how they do this, like, and where and since when you're doing this and all that type of stuff. Try to understand it and take it more as a conversation, not as a judgmental interview. Like, why you do this? Or no, this is not, no. Never like go and confront his ideas or their ideas because sometimes it could be a family. So first, I would like to understand him. And second, tailor the specific approach with him. So now that I open this, please feel free to share your thoughts or any other like value thing that could serve right now.
Yeah, no, I agree absolutely. And I think also like acknowledging just the cultural aspect of it. Like, I know that curanderismo is important to you. Like I feel like that could even itself go a long way just to making the patient feel like, okay, like they understand that this is important to me. I think it could really help. Um, but yeah, does anyone have anything to share, anything that they would like to add?
Yeah,
Yeah, I have a question. Oh, sorry. Go
go
ahead.
ahead, go ahead.
Oh, thank you. So how would you approach, let's say, for example, a patient's, mother's really sick, has like a neurodegenerative disease, and like a younger child is more open to like conventional Western medicine, but let's say like the father is not so open and is more so like trusting of like traditional medicine. However, like those have failed. How would you approach discussing that with like an elderly figure and you know do like basically discussing that?
Okay, so that's a good question, and I will give you experience again how we approach this. So first, I usually ask, hey, what type of treatments are you using? Are you using herbs? Are you using any type of tea or whatever? And then I ask, hey, at what time of the day you're using this? For example, sometimes they tell me, hey, I used to take this tea at 6 p.m. for this for arthritis. Like I'm treating my arthritis with this type of tea, and it seems to help. So the other thing is, okay, now for this tea, I would like to add something else. Like I would like you to take this pill in the morning. So now we're doing this treatment with two things. With your treatment in the afternoon or in the evening, and our treatment in the morning. So I will always try to get together these two treatments, not to tell them like radically, no, you should stop this, you should not take these medications because it will interact. No, first we will need to investigate. Okay, what type of herb you're taking. Also, taking into account that there are some herbs or some compounds, some natural compounds that could interact, like for example, some inhibitors of the CYP3 or some inducers. So we need to be aware of that, like ginkgo biloba, like ginseng, like some amount of medication. So always ask, then investigate. And if you notice that there is no interaction, no actual interaction with your treatment, you could encourage them to continue, but at a different times or make them like feel that, okay, they're doing this, but we're going to add this to their treatment.
You.
Okay, so anyone else want to add anything, or do we move on to the next case? Mahida, you were going to say something?
No, I was just gonna piggyback off of what you guys were saying earlier about kind of, making it making the patient know that it's a team effort and that like the sorry, I forgot the name of it. Curandero? Is that it? The curandero, like as well as like the other treatment options are both can both happen at the same time. Um and like that collaboration is really important and making like helping the patient know like, hey, like this can be a joint effort and doesn't have to be like you against me. Like it doesn't have to be like that. It can just be like both of us working together on the same team. So,
Yes, correct. I agree with Mahita, but there are so many scenarios that, for example, after a fracture, so we do a immobilization of the joint, and then we would like to that joint to be the immobilizator for a month and a half. So what we used to tell the patient, okay, we're working. I know that you like the curandero. I know in my country they call it sobador, and the people like to go to the sobador. The sobador, they touch the patients, they move the fractures and all that stuff. And we tell the following. So, okay, I know that you like the sobador or curandero, but first, let us immobilize this for a month and a half. And then after this, you can go to the sobador to do your treatments. But first, let your body heal with this method, and then we can add this. So there are certain situations that we need to be very specific, but actually with empathy. We talk with empathy with the family members. All right.
Thank you for that. I feel like, yeah, no, that makes a lot of sense. But yes, we could move on to the next case. Okay, so do you want to read that one, Mahita?
sure. Juan, a 45-year-old Hispanic male, is recovering from a spinal cord injury. He lives with his family in a multi-generational home, and their diet includes traditional high-sodium foods. Examples like beans, chorizo, tortillas, and he has been instructed to follow a low sodium diet to manage his blood pressure, but he seems resistant to making the change. So, how can you approach the situation to build trust with Juan and his family while encouraging healthier dietary changes? What role does cultural humility play when discussing dietary restrictions that may conflict with the family traditions? And how can empathy be shown in addressing his cultural beliefs around food and family meals?
So again, guys, like in this, like this is a very typical scenario like we encounter usually in primary care, and I got many experiences in primary care back in Ecuador. So and related to sodium, first, we all as a doctors we're used to tell patients, yeah, sodium, but some of the patients they don't even know what sodium like. We need to explain, hey, this is the salt that we're putting to our food, or there is some food that has a like high amount of salt. So first, the first approach will be like to explain them what is sodium like. And if you want to be more specific, you can explain a little bit how sodium works with the water balance and the high blood pressure. But the key question for me was, and I discovered that this changed a lot in how they start behaving, was okay, when you start preparing your soup, for example, how many cups of salt you put? And they'd explain, yeah, a little cup. But a little coop could be very different from you, from me. So I usually ask them to bring their spoons or whatever they use to cook to show me how many spoons. And I discovered one day that they would put a salad spoon, like two of them, to the soup. So yeah, so you should try to play like investigator with them, and then starting from that. Okay, now I would like you to put like half of that spoon. Maybe it will not taste that good at the beginning, but you will get used to always like encouraging them, like, hey, these little changes will help you. But first, try to understand what they are doing, how they are doing, and also try to implement the change, like not drastically, like like as little steps by little steps to enable to get like main or real changes. Also, how we how we track the changes. That's another thing. Like because we recommend something and then we forget to follow up and explain why we're making this recommendation. Or for example, in this patient, we want to control the blood pressure. So first we need to tell them what is a normal blood pressure. Where are the normal blood pressure values? Then what is an abnormal blood pressure? What have you? And then where is the patient at the moment? And after that, we will need to set a goal for him to understand, okay, I'm doing this because I want to get to this goal of blood pressure. So always when a person, we don't need to have that high level of literacy, of medical literacy to set a goal, to set a small goal, and they will feel more compromised. They will feel more involved in their own care. It's just different than saying, okay, you need to stop this because we want to lower this. They will feel like, I don't understand why the doctor is telling me this. So, but if you explain it, the whole process and what is also your thought process, they will get engaged and they will participate more actively in this change.
Yeah, and I wanted to add also even trying to figure out like, oh, like who is involved in the meal prep process, like getting them involved and, trying to find like alternatives to foods that they enjoy because of course that's very difficult, but reminding them like, you don't have to completely cut certain food out, but let's figure out a way to still have that like enjoyable meal. Maybe just reducing the portions, maybe again like finding an alternative. I think that's very important because in a lot of Hispanic cultures we have dishes that are very important to like our identity and just like even eating as a family, it really helps us connect. So I think not being so like like you have to completely cut it out or like no salt. I think it's important to always come in with that sort of approach. Does anyone have anything to add or any questions?
I have a thought. I think also like I know some primary care like FQHCs, they have like these health educators that you could possibly um I guess give them resources to that, and they have like these culturally appropriate, cookbooks and stuff. So just giving them options there might help too.
Yeah, absolutely, absolutely. Giving them options, like if you could elaborate like a table or something already tailored for them, like it's really helpful. For example, like telling that corn tortillas are better than like, I don't know, other type of tortillas. I'm not a master in tortillas, but yeah, yeah, that's pretty cool. Or white bread instead of like other type of bread, like some things like that, or something specific to their pathology too.
And William said, I've noticed that a lot of grocery stores, they'll offer the same ingredient, but with no reduced sodium, maybe encourage them to look at different stores or around on the shelves to see if there's an alternative option. Yeah, that makes a lot of sense. Okay, so I think we can move on to the next case.
I
Yeah,
actually have a
sorry.
question. Oh, sorry. Go ahead.
Oh, yeah, so I had a question too. Um, I think like one thing that I've noticed in terms of like getting access to like healthy foods is that it's usually like priced more expensive. Like if you want like the healthier option things, like usually like if you go to a store like Whole Foods or something, it's more expensive than going to like a dollar store or something to like get your groceries. So I was wondering how y'all like approach factoring that. Because I think like culturally, like from my experience, ethnic foods or ethnic grocery stores are usually less expensive. And then there's like less of an emphasis on health labels because like if they're imported from like their home country, the ethnic grocery stores, like the foods don't have the same sort of labeling that American grocery stores require. So I was wondering if anyone has any suggestions on how you tackle that into the conversation too. Because I think a lot of times like our patients, especially like ethnic minorities, have to deal with the fact that they can't like afford the fancy stuff like at Airline or something.
So can you hear me? Yeah. So what you're telling, like it's a reality. Like it's a reality that we are living in this country at the moment. So the acquisitive power, like it means a lot here. But some strategies that I should use, like for example, coming from Latin America, there like not all the people could have the access to a lot of protein from animal meat. Instead of that, I always used to recommend like quinoa or some grains that were an alternative to obtain that amount of protein that the patient was needing at the moment. So what I usually used to do was like did some research and then looking for alternative, like the less expensive alternative, and starting from that. Like, but as you mentioned, like it is kind of difficult to now like in 2025 reality, like this healthiest or safetiest food, it is getting more and more expensive. But we need to understand something that the consumption of these things, like of the unhealthy things, it's being not that regulated. Maybe the amount of things that they're consuming at the moment were not the right ones. So also a little bit of education in the right amount of the the food, the actual food that they need to ingest, will be something helpful too. And let them know that hey, you will not need to fill that whole plate to feel satisfied, like, or this is not in your calorie requirement. So with this, it's enough. And if one grocery store like purchase for a week, maybe now could last like a week and a half. So that will be a win-win for everyone. I don't know. That's my perspective again.
Yeah, I think with some, I mean, I agree, like with some products, you won't see that like nutritional information, but I think in general for like, like the meats or the rice with those things, I mean, ideally if they could weigh it, I know it's not always the most feasible thing, but I think that would be the best thing in general, even if they had like the calorie amount. Just in the beginning, I think it's important to emphasize like, okay, like let's weigh things so, patients could become a little bit more aware of what the quantity is. I feel like when I first tracked like calories, I didn't realize like, wow, like these, two cookies are like 200 calories. And I can imagine like that happens a lot, with other things like rice or even like the tortillas, for example. So I think even like just reminding them that like, okay, let's maybe just track it for 1 week or like a couple days and then use that like going forward to monitor better like what they're eating, their intake. Okay, so does anyone have any questions or any thoughts? If not, we could move on to the next case. Okay, so we'll do the next case. Okay, so case study 3. So Lucia, a 42-year-old Hispanic woman, was recently injured in a car accident and now requires ongoing physical therapy for a shoulder injury. She's undocumented and worries about the cost of treatment, transportation to appointments, and the risk of being asked for identification. Because of these fears, she has been inconsistent with therapy and is considering stopping altogether, despite continued pain and loss of function. So, the questions we're going to go over are how can you approach Lucia's concerns about access to care while being sensitive to her fears about her immigration status? What community or institutional resources might you connect her with to support her treatment and reduce barriers? How can cultural humility guide your approach to building trust in this situation?
I would like to hear your perspective, guys, on this, and then I will add my opinions.
So yeah, guys, so what are you thinking? So, right, this is a very real thing right now, unfortunately, that a lot of people are facing. So you have this patient, she's going through this, like what are your next steps? Like you see she's not coming to therapy, she's scared. How would you approach that interaction?
I think for me, I would first just like create a safe environment, especially if she's already nervous. And I think I would then maybe give her like all the information that you would need, like a patient is needed to provide at a visit for healthcare, because sometimes like there's misinformation and then you think you need all these documents, but you really don't. But then I understand like sometimes in this environment, like sometimes it's not always you're still scared at the end of the day. So I think maybe also providing like home exercises would be good. Just like tailoring to each patient, but for her specifically, it would be the home exercise and trying to see like maybe outside the visit, what places like in the community provide free healthcare and like pop-up workshops. I mean, pop-up like healthcare clinics as well would be good. That's how I think I maybe I would.
I agree too with Alexandra, and also I would not like to enter in the immigratory things, but like I will my recommendation will be like to channel it with the social workers that we have available in our hospital, and also to let them know that we have like the county medicine like for this type of population. So there is actual like access to care for them. Maybe they are afraid of getting involved in this due to their migratory status. But like as again, as Alexander mentioned, like tailor something like for them or inform them. Like for example, some of the patients that I encountered working in a rehab facility was like some one problem with them was the transportation. So also, we need to be aware that we have services here, like for example, Metrolift in Houston. They charge like a minimum amount, and they can pick up the patient, take him to the appointment, and they take it back home. So there are some resources like that. Like I'm talking about the Houston area, but every city, I believe, should have these type of resources for them. So being informed of the reality and also being informed of the resources for these type of patients, it should be very useful.
I was also going to add, in terms of like transportation, now let's say that she is actually in like a rural area where there's not as much like trains or like like metro access. So currently right now I'm in Scranton, Pennsylvania, for like my rotations and stuff. And so one of the ways that they help with transportation is like they the community health center has like these like almost like shuttles that take patients like from place to place, and then also like a kind of like an Uber driving service where they like pick up patients, take them to the appointment, and then drop them back off. But I don't know how many like rural areas are like able to provide those kind of resources, but that is like something that like that's done at least in like this area. So there's also that portion.
I think, yeah, like I agree with everything everyone has said. And again, just like always remembering to start off by like acknowledging her concerns, like the patient's concerns. And just remembering that, depending on what community you're working with, it's important for us as doctors to be aware or try to be as informed of resources for patients. And of course, like social work, that is a lot of the responsibility, but it's also imperative for us to be advocates for these patients. So trying to, make sure that you're aware of like, okay, maybe there's this community health clinics, health center, or like there's this program that caters like has makes it more financially accessible. Or I mean, if telehealth is available in a way like that, like tele rehab is available, like that would be really cool. Like I don't know if it would be covered, but again, like trying to be up to date with what resources are, I think that could make a big difference.
Yeah, I actually had a question about the telehealth and possibly doing it virtually. What are the considerations with that? I assume I would think like that would be more like later on in the rehab process, like not so much acute. But what are some limitations with that, and as well as like home health PT, um, sessions?
Casey, sorry, could you repeat your question?
Oh yeah, I was just wondering like what are like some considerations you might have if you were to do like a telehealth visit for this patient who has fear about me possibly going into the clinic, because I could see like how telehealth could kind of ease those fears in a sense. What are some considerations implementing that, or like limitations to implementing that, as well as possibly like doing a home health, like a PT visit?
Yeah, so but first I would like to go over like as a doctor, like we're so in order for them to get a consult or an actual appointment with us, like we're not the ones who ask, okay, what is your immigratory status or something like that. So if there is a system in place in the hospital to for telehealth or like telephysical therapy, like it should be that those arrangements should be done before be they get in touch with us, if that's my understanding. But always we need to know like what is the process or how we can channel the patients or how can we inform the patients to get these type of things. But I believe like that this is an advantage. Like in the rehabilitation field, I noticed like since the pandemic, like they starting to do the following, like the follow up consults. Like I had experiences just right after the pandemic, and for me, it was impressive. Like how a spinal cord injury clinic, like they arrange all these meetings, like with the patient team, the patient family. Sometimes there were some PT on site with the actual spinal cord injury specialist. So it was awesome for me. Like for me, it was like, oh wow, like they're continuing with the care during this time. So like, yeah, I believe like it will be beneficial, but I could not tell about like from that migratory fear perspective.
I see. Thank you.
Okay, does anyone have anything else to add, or should we move? We have two cases left. Okay, so let's move on to the next one. The next one is family dynamics in care. Mahida, do you want to do that one? Okay. Yep.
Sure. Isabella, a 72-year-old woman with osteoarthritis, lives with her daughter and her grandchildren. She reports that her daughter manages most of her medical decisions, including what treatments or therapies Isabella receives. Isabella feels like her daughter's making decisions on her behalf without asking her opinion, and this makes her uncomfortable. The discussion questions are, how can you involve Isabella more actively in her treatment planning while being respectful of the family dynamic? And how can cultural values around family roles and respect for elders impact healthcare decisions in Hispanic families? And how would you use cultural humility to address Isabella's discomfort in a way that promotes her autonomy while respecting family dynamics?
Okay. So this case is very typical case, like in the inpatient facility. So perfect example, 72-year-old female with maybe a daughter, like born and raised here in this country. So she's been always on top of things. Like she was the one who paid the bills. She was the one who gave her cell phone to that person who knows about the insurance, who knows about like everything. So that dynamic sometimes like aligned with the family dynamic back then in their original country, but sometimes it could like contract. So that is a kind of difficult situation. So the important thing here is like a family meeting, like something that simple as a family meeting. Like first you understand what is the dynamic in this family, how they've been taking decisions in their life. And if the mom is the one who took the decision, for example, like patient related decisions, like we were going buying this for groceries, blah, 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 or any other things, and who is taking the medical decisions in family. Then another thing, acknowledge and understand that this type of patient, 72-year-old patient, because they don't speak English, it doesn't mean that she doesn't understand what is happening. If you take the time and explain her what is happening in her language or in basic words, maybe he will be able to take a decision in conjunction with her daughter. So this is the thing, like explain the whole family. And also, if there is any other family members, take the time to explain them too. And then this type of like family gathering, like this decision making, like plan, it's something that actually works. And for them to not make them feel that you're interfering. No, you're just putting the information for them to take the decision. Also, there is a typical thing, the other typical scenario that some grandma, like 72-year-old grandma, she's like, no, whatever my daughter says, I'm gonna do. Yeah, that's fine. But also take the time. It doesn't matter if she just relate on her daughter's decision. Take the time to explain her for her to feel first care and also understanding the process. Because it will be better for her when he goes out of the hospital to say, hey, I had this, and this. For example, some people doesn't know why they're receiving a red blood cell transfusion. So first take the time, like, hey, the blood has something called hemoglobin. So the normal values of hemoglobin are these. You're having these values of hemoglobin. And in order to help you increase these values, we're giving you red blood cells. Another patient, when he goes out of hospital, she will say, hey, yeah, my hemoglobin was low, so it was supposed to be like this, but it was like this. And that's how I received this red blood cells transfusion. They will not say, like, they just put blood on me. No. So always like inform the patient. Inform the patient because it's their body. But if they relate completely on their son, on their daughters or son, you need to respect that. Also, like here we have like something called medical power of attorney. So we will need to ask if they have those papers on place and all that kind of stuff. But also always remember to give information and let them discuss and absorb the information and give them time. This is another thing. Like sometimes if we are in a hurry, we want an answer right away. No, give them time, let them process, let them talk, and then you can come back again to make an informed decision.
And I also wanted to add that in many of these cases, like when you do have a patient who, maybe their children or a family member is doing a lot of the translating, how imperative it is to make sure you do have a translator, even if like, the child or the family member speaks Spanish for many reasons, First of all, like the translation might be incorrect. On top of that, depending on what the family members maybe they prefer, like you might not know what they're translating exactly, so it just kind of makes everything a lot easier to navigate, I feel like, for the patient too, to just get that information, the most accurate information. So just like wanted again to reinforce, like, again, making sure to use the medical translator. And yeah, like always like thanking whoever the family, like, let's say in this case, the daughter, thanking her for her support, but reinforcing like, okay, like, so let's bring the attention, to the mom. And I think that could really help with, especially in the family meetings.
Yeah, I agree with Ellie, and I would like to add something else something that I just encountered. Like for example, in a discharge summary, like sometimes you need to put the follow-up visit, and we sometimes we don't ask the patient, so we just tell, okay, you need to come this, and this, or what day will be. We don't want to ask what day will be preferable for you, so it's like in 2 to 3 months. But you can arrange that thing. So for example, this patient, her daughter was speaking in the mornings for the follow-up visit. But this old lady, she liked to go to church in the morning. So she was kind of like sad because like she was about to miss all her churches, so all her masses. So yes, always ask, hey, so what about this time of the day that will be good? Or like keep in mind that September 15 or December is like Virgen de Guadalupe thing, and like people like take time to do that type of thing. So yeah, always like taking into account these type of things, and also not just for Latino population, for every culture, because we have Jewish, we have Middle Easterns, we have Asians, and all these cultures have like a specific like dates or ceremonies or parties. Like, so be always mindful of these type of things.
Okay, guys, we're up to our last case. Before we move on, does anyone want to add anything, ask any questions? Okay. Move on to the last case, which is about pain management and resilience. So we have Eduardo, a 50-year-old Hispanic man, has chronic back pain due to a herniated disc. He has been prescribed opioid medication but expresses hesitation about taking it. He believes that suffering is a part of life and doesn't want to rely on medication. His family also shares the view that pain is to be endured rather than treated with medication. So, how would you address his concerns about pain management while respecting his cultural values? What strategies can be used to educate him and his family about pain management and the role of medications in improving quality of life? And how can cultural humility guide your approach to discussing pain and suffering, especially in the context of the Hispanic value of resilience, which is what usually you would hear of as like machismo, is what we hear a lot. But yeah. So I'm gonna open it up if anyone has anything to share.
Yeah, so this is another very typical case like we encounter in our community. And sometimes I responded like that too. When people ask me, how you doing? Fine, fine. Maybe if you could be destroyed in the inside. But yes, so first, like make a safe environment for them. Like what people also the Latinos, they will always never tell you the first time you ask that this pain is terrible or whatever. They'll say, yeah, it's a little bit painful, but it's good. No, tell them, hey, I usually use this like, hey, yesterday I was playing soccer and I turned my ankle, and I could say that is a 3 out of 10 in pain. So right now you're in pain. If this is a 3 when you turn your ankle, have you turned your ankle? Yes. If that was a 2 or 3, so right now, what is your pain? So put it in context or something or experiences that may have felt before for them to understand that. Another thing with pain also that always you need to remind them like the PRN pain medication. So some of the patients they have scheduled pain medications every 8 hours. So sometimes at hour 6 they are they are feeling pain again. So but because the doctor says like if every 8 hours, I need to wait in pain till the next dose of medication. No, explain them. Hey, I'm gonna prescribe also PRN medication. Explain what is PRN. And if you're feeling pain at hour 6 or hour 7, let us know and we will put you something and we will give you something. So this is what I usually do. Like before leaving like the area where I'm working, if I know they have a Latino patient that I've been noticing that is a type of person that is not like talking about anything or you're just quiet. Before I leave, I said, hey, I'm gonna come tomorrow overnight. If you're feeling pain, we have these options. Just let them know that the pain is increasing and use your PRN medication. There is nothing bad on that. So explain them that. Another thing that is very common and it's like similar to pain is withdrawal symptoms. So there's some prejudice in this. Like for example, a cirrhotic patient due to alcohol consumption, they are hospitalized, and of course, at day 2, 42 to 72 hours, like maybe after their last drink, they're feeling withdrawal symptoms, and they were feeling anxious, like they will have started tremors. And when you ask them how they're feeling, they will say, "Good, good, good." No, you need to tell them, "Hey, nobody's gonna judge you here. Let me know if you're start shaking or if you're still feeling anxious. if you feel palpitations or something like that, because I could give you something, I could help you with something, but talk. So encourage them to talk. So that will be my recommendation, specifically with them.
I have a question.
Yeah.
Um, so from my experiences in acute rehab, like one of the things that I see a lot of the attendings doing is that if they have like a minority patient, someone who doesn't speak English as a first language, and they know that culturally or language barrier wise, they aren't going to be like that into the fact like the idea of asking for PRN payments, they often just do it scheduled because they believe like these patients are often just like going through like the pain, whether it's for like a cultural belief or like because they feel like it's bothersome to try to like communicate using their language rather than English for the pain meds. How do you like I understand like that's like an easy way to deal with things, 'cause especially like if you're like having like a list of like 10 plus patients that you need to see. But like what are your thoughts about like just putting these people on scheduled pain meds instead of just PRN, just so that like you at least know that they're going to be receiving pain relief?
Sorry, I couldn't hear the last part of your question. Sorry, if you could repeat it, please.
So, like, do you have any thoughts about like this whole idea of like just putting like these patients that you assume aren't going to like ask for PRNs when they actually need them? Do you feel like that's like good practice? Do you think there's a better way to like manage this?
So, so this is the thing, like with pain is very subjective first, and you cannot start prescribing like high doses of pain medication to every patient, but at least to inform them that they have options, and also adding to that, like inform them that they have the option of having a translate. So that's another key thing too. You will always have an option to have your translator. Don't be afraid of that. But like in regards of like making a fixed prescription to every patient, I believe like the pain management should be very tailored to case by case.
Yeah, and I just wanted to add, the other thing is talking to the patient and expressing that pain relief isn't about weakness. I think that's how a lot of people see it as. So just reminding the patient, like that doesn't mean you're weak. Like we can work, around this. We can have this pain, gone away. So just kind of reminding them that could hopefully make a difference. But yeah, does anyone have any? This is our last case. Does anyone have any questions, any thoughts, any maybe share any experiences that you had where you were like, oh, like I didn't know how to navigate this, or this was tricky, or like could I have done things differently? Um, yeah, opening the floor for that. If not, we can end here. Um, but again, like thank you all for joining. This was really, really helpful, and I feel like it's so important for us to, have these conversations and go through these cases because it's something we do see and will continue to see. So I think it'll make us better physicians.
Yes, guys. Thank you. Thank you for the opportunity. And like also, we'd like to remind you that healing is not just physical, like as we notice in these cases, it's cultural, emotional, and relational. Like cultural humility should not be a checklist, like it should be a mindset. Like we are in this mindset, always in this mindset, not just for Latino like community. We're talking about Latino this month, but for every community. So this means recognizing our own biases, like listening deeply and co-creating this new care or not new care, this care for this patient. So as we reflect on this, like let's commit on building this inclusive community. And thank you again, guys, to the Jedi community. And yeah, hopefully we'll see you in the future.
Sounds good. Thank you so much, everyone, for coming.
Thank you, everyone.
Yeah. All right. Bye.